Anybody can say, it doesn't just have to be an intern. Hi guys.
It's a tool that's used to assign urgency to the patients in the emergency department with which they need to be seen.
Okay, cool. All right. So we have a triage tool, but the term triage comes from Napoleon times. When Napoleon had a chief surgeon, his surname was Larry, so Dominique Jean Larry, 1766 to 1842, and he was the chief surgeon in the French army, who became really well known as the military surgeon who's often accredited with the development of the triage system. So it comes from the French term to sort. And what they did is initially, during war, it was often the officers that were treated first, and the regular footsmen and foot soldiers were not necessarily treated first. You were treated based on rank. And this French military surgeon introduced this idea of triaging patients and treating those with the most severe injuries first. And he actually introduced the first EMS system, where instead of taking patients to a hospital, they took a horse and a cart, they put the patients in the back of the cart, and they took them to where the military surgeons were on the battle side, essentially on the side of the field. So introducing the first EMS system as well on the battlefield. So as I was saying, it comes from the French word, and it means to sort. One of the most important things that we need to understand is that triage is not just about vital signs. Everybody thinks, great, if the nursing team has done the vitals, they've done the triage properly. That's not actually true. Triage is much more than vital signs. Vital signs are an important part of triage, but it's not the be-all and the end-all. Actually, it's requiring clinical skill from us as clinicians. It also is not first come, first serve. So please don't think that just because the patient who's shouting the loudest, that they were here first, that's the person we need to see. Usually the ones that are crying the loudest or shouting and waving their arms around are the persons who most likely don't need to be seen first. So triage is a system of sorting that is encouraged, and as set out by the Millennium Developmental Goals, we are trying to reduce under 5 mortality. So the integrated management of childhood disease, in conjunction with UNICEF, teaches something called the ETAT course, the Emergency Triage and Assessment Triage course, that is looking at childhood illnesses in order for us to reduce under 5 mortality. So the integrated management of childhood disease and the ETAT course teaches us to look for children, detect hypoxemia and the use of oxygen therapy, because this saves lives. Also, it teaches us about the management of infants and children with impaired circulation, how to identify them and to manage them, and also the management of seizures. Rapidly being able to identify patients that are in respiratory distress, might have airway issues, patients that have impaired circulation and might be shocked or dehydrated, and children that are having seizures. This is something that we can do upfront and immediately, and it's a visual clinical inspection that doesn't necessarily rely on vital signs. So as I was mentioning, the integrated management of childhood illness, there have been many versions of this, and each country has adopted the WHO standards and introduced them into sort of a local setting. And indeed, we've got our own IMC, and you'll find it at that website. And it just takes you through the common childhood conditions that we need to be able to identify and treat in the emergency department. The ETAT course was first developed in 2005 by the WHO, and it's actually been an updated course taught in 2016. And whenever you do a PEDS course on rapidly identifying danger signs, in critically ill children, this is the course on which a lot of the information is based. So when we're in triage, you got to understand it's a really difficult task. And in South Africa, we're often a nurse-based triage because we don't necessarily have enough staff to run a triage system. Although if you're working in our pure PD at Rahima, you'll find often that there is a senior clinician working in triage because they're putting together nursing and doctor skills. We don't always have the luxury of that in an emergency department. So when it comes to triage, actually what it is all about is our powers of observation. It's being able to look at children, do a quick, rapid head-to-toe survey, looking at our ABCDEs, and rapidly identifying children that are at risk. So the first thing when you're triaging a patient is, are they dead or are they alive? Okay. Are they good or are they really, really sick? So this is the first one. Please be very wary of moms that are sitting in a queue with babies wrapped up in multiple layers of blankets, or a patient that comes through triage or into the ED that's wrapped up in blankets, and the triage sister says to us the patient's condition has changed. Very often that's code for this is a cardiac arrest. Okay, so as I say, we always look at the patient. Do they look okay? Are they perfusing? Are they running around? Are they playing? Or do they really look sick? Are they floppy? Are they distressed? Are they pale? Are they bleeding? Okay. So we do something called the pediatric assessment triangle, which has been well described in emergency medicine and pediatrics. And it's a tool that is taught if you have done pediatric, advanced pediatric life support, so the PALS course taught by WHO. It's also well used in EMS as well. So there's a few things that we do when we're walking up to the child. We haven't necessarily even laid hands on the patient yet. We're looking at their appearance, we're looking at the work of breathing, and we're looking at their circulation, their skin. So a few things we're looking at when we're looking at appearance. We're looking at their tone, how interactive are they consolable by the parents, are they crying, are they running around? Okay, look at the work of breathing. Do they have abnormal sounds? Is there stridor? Is there wheezing that you can audibly hear? Is there stertor? Is the head bobbing? Are there signs of respiratory distress with intercostal recessions, subcostal recessions, supraclavicular tug? We look for all of those kind of things, and nasal flaring, as well as inadequate breathing or absent breathing. So we look at the circulation, and the skin is a good sign for giving us a clue about circulation. So we look for pallor, is the skin mottled, are they blue, are they cyanosed? But also then we go and see, is there a present pulse? And we have a look at further vital signs if we have access to them, even better than the blood pressure, because it's always available as a cap refill. So part of every single triage is to do a capillary refill sign, and then obviously look for signs of breathing. If there's problems with any of these areas, right, you need to move faster. Okay, so what about pediatric triage in South Africa? Well, our South African triage score, the SATS, first started as the Cape triage score, then it was developed into the South African triage score, and we did a modification, the South Africans did a modification that adjusted the vital signs for children, and it became adopted as a pediatric triage score in South Africa. And if you want to find out more information, go onto the Emergency Medicine Society of South Africa's website and have a look at the South African triage scale. So this should be familiar. You've got a copy of this up in all of our departments, where we've got an adult and a pediatric triage score or chart. This is the PEDS one, and I'm going to take you through step by step. First of all, before we even start vital signs or write down a whole history, we look for emergency signs and ask about the presenting complaint. So obviously we're worried about A, B, C, D, E things. So if there's an airway or breathing issue, so if the patient is apneic, there's stridor, obstructed breathing, it could be just secretions in the mouth or the tongue, or they're snoring, these are things to worry about. You need to put on the SATS probe and have a look, and if the SATS are low, we need to be worried. And if there's signs of severe respiratory distress, we need to act fast. We don't even start with vital signs in the triage area. We rush the patient right to a resuscitation bay, and we do the vital signs in the resuscitation bay. This is an So this was a video where you could see signs of obvious distress. the snoring, the intercostal recessions, and the significant noises as well. You can audibly hear the sounds and the work of breathing. So this should really worry you if you find a patient like this. You want to take action rapidly. It's another patient with respiratory distress and signs of nasal flaring and some seesaw breathing with increased abdominal work and muscles of additional muscles, so accessory muscles of respiration. Okay, so any airway breathing signs, don't do the vital signs in the triage area, rush the patient to a resus area, take the triage book with you and do it there. Okay, if we have circulatory signs, then we need to be worried if the patient is cold and has got two or more of the following. So they've got a weak pulse, if it's thready or if it's fast, if the cap refill is very delayed, so more than 3 seconds, or if the patient is super lethargic, or if the patient has got uncontrolled bleeding, and we don't mean epistaxis. Okay, when we're doing cap refill, we need to do it for long enough. So it must be, you hold it for at least 5 seconds. If you're doing it on the chest or on the fingers, it has to be at the level of the heart, right? So you have to press for long enough. This is a sign, obviously, of a delayed cap refill on this little kiddo. It's got to do it properly, and we're looking for signs of poor perfusion. Okay, if the patient is having active convulsions, seizures, and it doesn't matter what kind of seizures they are, it's an emergency, or if the patient is incredibly post-ictal and not alert immediately after seizures. Doesn't mean that they're rousable and that they're moving around spontaneously. It means super post-ictal, as in they've just stopped fitting now. Okay, so any little kid having seizures, please rush them straight through to the ED because we want to sort them out immediately in the resuscitation bay to a monitored bed. Okay, also if they're having coma, so coma, convulsions, assess the AVPU scale. We don't calculate GCS up front in triage, it takes too long. Try and calculate the AVPU scale because it's a much better, easier assessment. Okay, so are they alert? Or they're only responsive to voice, or they're only responsive to pain, or they're completely unconscious. And document this in your triage assessment. If they're significantly dehydrated, so diarrhea and vomiting with a floppy, lethargic infant, very sunken eyes, and a very slow skin pinch, that is a patient that's severely dehydrated. You also don't do vital signs with this patient. You rush them straight to the resuscitation bay and do vital signs at the same time as resuscitating them. So this is a kitty with a really decreased skin pinch. Okay, so obviously this child might have something more going on, like severe acute malnutrition, but regardless, this is a really bad delayed skin pinch, and we would also rush this child through to a resuscitation bay. Okay, anything else that we find, so the ABCDEs, that would also make the patient a red patient is facial inhalational burns, and that's usually flame burns usually. Hypoglycemia, okay, if the glucose is currently less than 3, or purpuric rash. So the hypoglycemia doesn't just have to be one that's reported by us in triage area. If the EMS has found the child hypoglycemic, or if the child was seen at the clinic before us and they found a low glucose. So these are all red patients who've got these signs. We rush through to the resuscitation bay and we do vitals there. Act fast and don't dilly-dally. If they have those emergency vital signs, as I've said, we take to resus. If none of those signs are present, then we're looking for very urgent signs. Okay, and the very urgent signs are as follows. Tiny babies younger than 2 months. They might be completely well. They might just be jaundiced. That's all that is wrong with them. But because they're small, they're like little aliens with very different physiology. We need to be worried about them. And please don't ever send a tiny baby away home without a very, very careful assessment. They're notoriously difficult to diagnose because they can only present with so many things, and you very well might miss it if we're not pedantic. Okay, if there's severe pain, you're an orange patient. If they're much more sleepy than usual, if there's poisoning or overdose, doesn't matter what it is. Focal neurology, if they've been involved in some sort of trauma with a severe mechanism of injury, for example, fall from height, PVA, MVA, motorbike accident, those are all severe cases. If the patient has got a burns of 10 to 15% or more, or if there's circumferential electrical or chemical burns, that's an orange patient. Eye injuries, particularly if they are penetrating, but also chemical splashes. Fractures, it's got to be an open fracture, or if the limb is threatened, it means you have to examine the leg and see is the bone poking out and felt the pulse, right? Because those are all orange patients. If there's a dislocation of a large joint, not fingers and toes, so shoulder, elbow, hip, though that's also an orange patient because it is a limb-threatening condition. Okay, so if there are urgent signs, then we can do the vital signs, and obviously then we need to hand over that patient to the doctor and the nurse inside the ED and tell them this is an orange patient, because we're supposed to see orange patients very soon. We're supposed to see them within 10 minutes or so. Obviously, red patients you're supposed to see immediately. Okay, if there are no orange signs, then we look for urgent signs, and urgent signs are the yellow patients. There's some respiratory distress, not severe respiratory distress. Some dehydration, so diarrhea or vomiting, or diarrhea and vomiting with one or more of the following. So only one, like sunken eyes, restless or irritable, thirsty, decreased urine output, so mom says they're changing the nappies less, dry mouth, crying without tears, and a skin pinch is slow, less than 2 seconds. So not severely dehydrated, only mildly. If they're unable to eat or to drink and they vomit everything, obviously that kiddo is probably going to need a little bit of help. You can't just send them home. They're a yellow patient. If the patient has malnutrition of any sort, so marasmus, kwashiorkor, severe acute malnutrition, whatever you decide, this patient usually is automatically graded as a yellow patient because they're higher risk and very well might need admission for their mild dehydration, their mild pneumonia, purely because the malnutrition is an issue. Okay, an unwell child with diabetes, burns less than 10%, closed fracture. So fractures are automatically yellow patients unless they're a threatened limb or a open fracture. And then dislocations of fingers and toes, and those are yellow patients. So these are all patients that can be seen in the ED. So we measure the vital signs and then we have a look at them. Okay. So with the vital signs, we now calculate a twos score, which is the triage early warning score, which essentially is just a number looking at our vital signs and coming up with a number to give them an indicator of whether their vital signs point to acuity or not. So if the twos, when you add it up, is a 7 or more, that patient is a red patient regardless of what you did or didn't notice clinically on the patient. And that patient needs to be then rushed through to the emergency department resuscitation bay to a monitored bed. Okay, take to recess. Okay. Obviously, we can't downgrade patients at any stage. However, you may upgrade. So if your patient is a red based on clinical signs or based on vital signs, you can't then go and make them a yellow patient or a green patient. However, if one of the scores was green or yellow and the other one is red, you are welcome to upgrade them. You're not allowed to downgrade them. Additional investigations that we might do in triage, we will check the respiratory rate as part of our twos calculation. So we'll look at respiratory rate and AVPU scale, mobility. We'll always count a respiratory rate for every single patient. Check the SATS, please, if the rest rate is high. They've got a decreased level of consciousness, you'll always do a finger prick glucose. If they can't sit or move, do a finger prick glucose. They've got diarrhea, start oral rehydration right there and then in triage bay. Vomiting only and some dehydration, then you've got to hand over. Severe malnutrition, you've got to do a glucose. malnutrition with edema, you must do glucose. Diabetes, you must do glucose, and it's a good idea to check the urine. The history of bleeding, we must also check a hemoglobin. Okay, so the investigations will depend on what is wrong with the patient. Also, if you find there's a senior healthcare clinician sitting there who's picked up some danger signs that maybe we, as the junior healthcare provider or the junior practitioner, hasn't noticed, understand a senior healthcare provider can upgrade the patient. It's never advisable to downgrade a patient. So please don't do that. That's how mistakes are made. If we've upgraded a patient, it just means we have to see them sooner, which is not bad. If we then find, oh, the patient is completely stable, that's fine. Don't bounce them to the back of the queue. That is not fair. You've finished seeing them. Okay. You'll see that there are different twos, so different vital signs for different age groups, because we know the vital signs are different for each age group. So there's one for a younger child and one for an older child. Please refer to the correct twos chart for the patient in front of you. Coming back to the triage sheet, that is what it looks like. So we've kind of just gone through the triage chart and how to use it, and things to watch out for. Green patients can be seen in the ED if there's something that needs to be attended to that is surgical. For example, the patient has a foreign body in the nose or a small abscess that needs to be debrided. So it might be difficult, or indeed, it might be difficult to send all green patients away. However, green patients technically can start at their local clinic. And those are the patients that will take the longest to see. A green patient will take anywhere from 2 to 4 hours to see, waiting in the queue. A yellow patient you should see within the first hour, maybe 2 hours. An orange patient we're supposed to see within the first 10 minutes, 10 to 60 minutes. And a red patient we're supposed to see immediately, which means between 0 minutes, like immediately, and 10 minutes, no longer than that. Just so that you guys sort of understand, I've just taken you through the very, very basics of the triage chart. Doing a triage is hard, doing a triage score itself is not good enough when it comes to triage. It has to be integrated into a system where healthcare providers can actually identify sick children, because that is probably more important than anything else, is for us to be able to identify which are the danger signs, which patients are the sickest, and which ones we need to identify now. Please don't leave out any vital signs. We need to do temperature, so carry your own thermometer, count the pulse rate yourself and comment on the quality. Always count the respiratory rate of every single patient you see. Do a cap refill, have a look at the AV curve, comment on mobility of the patient. And if you're able to, and we luckily do have blood pressure cuffs of all sizes, do a blood pressure for the patient. I hope this was a quick but easy introduction to triage. I'm going to stop sharing and I'm going to ask if there are any questions or any comments. Any questions, any comments on this really basic introduction to how to do the triage score? Any comments? Any questions?